of a case, perhaps, Dr. Spargias. So let me ask some of the commentators. Dr. Baikoussis is not here. But Dr. Petropoulou is here, and I think he is a suitable person to comment on all these things.
Thank you, Dr. Tsiapras. Thank all the speakers for the excellent talks. It is an amazing topic, the replacement or the repair of the mitral and tricuspid regurgitation, because as the population getting older and older, we have more patients that survive after an ischemic event and then they develop mitral regurgitation, more patients with mitral annular calcification and mitral regurgitations, more patients with long-standing atrial fibrillation who develops mitral and tricuspid regurgitation at advanced stage, and more patients who survived after cancer treatments. And after that, after the treatments, they have tricuspid regurgitation mainly. So my point is that the most important after expertise is the selection of the patient. So we have to be very careful in the preoperative evaluation of a patient, and we have to use all the imaging techniques, I mean ultrasound and CT scan, very careful, to assess the valve, the ring, and the LV geometry in order to have a technical success. Thank you.
I think it would be very interesting to discuss and see the opinion of the speakers. Especially Professor Maisano, you talk about clearly an excellent presentation as expected, but you brought the issue of the increase in the use of the Mitraclip, which we all agree it's going to happen since you have the trials, you have the data. At the same time, we heard with Dr. Carr some promising data with the mitral valve replacement. So my future concern might be you lower your threshold on using the Mitraclip, probably to a low-risk patient, surgical risk, then you ended up having 2 or 3 Mitraclip in the mitral valve, and then you will not be able to replace the valve percutaneously. Is that something that we should bring into our attention in this early stage?
Excellent question. It's obviously is a big discussion at the moment. There is some concern. If you implant clips, can you then replace these valves? First of all, it has been already done. I've done one case. There are some cases in the United States. I don't know if Cyber has done some of those. You can actually be able to implant the valves also in patients with clips, because you can use the so-called lampoon, modified lampoon technique to make your space within the anterior leaflet. You can actually cut the anterior leaflet and implant the valve afterwards. So it is not 100% possible to treat all patients after Mitraclip with transcatheter replacement. And for this reason, I believe there is room, particularly in early stage procedure, in early stage disease, for annuloplasty, which leaves the door open to anything else. So I'm not saying the Mitraclip will be the leading solution forever, but at the moment, due to its simplicity, is the working horse. The problem is anything like annuloplasty or replacement needs a proper patient selection. You need to look for CT scan. You need to also have special anatomies, the position of the coronary, the size. There are a list of exclusion criteria for these procedures. And the difference is that Mitraclip needs nothing. It's just like you have the balloons and the stents in your cath lab. The patient comes, and you can, in principle, do ad hoc procedures. In principle, The problem with Mitraclip anyhow remains, it is not a device. It's not a it's not a therapy. Abbott has been pushing this concept that there is Mitraclip therapy. There is no Mitraclip therapy. Mitraclip is a tool. It's like a suture in the hands of a surgeon. And there is not one suture which is better than another suture. There are good surgeons and bad surgeons, not good sutures and bad sutures. So Mitraclip, Pascal, whatever, these are tools that can be used to repair valves, but they have to be used appropriately. And to achieve that level of competence, it takes years of experience. It takes a team of experts around the procedure. It's not only the operator. And therefore, we need to strive for center of excellence. This is the next step that we have to also reinforce. It is important to gather together the operators, maybe from different hospitals in one center, to do more procedures and to keep the volumes rather than diluting. This will be possible with the replacement, but not with the repair.
Yes, whoever.
I was about to ask about the same thing with you, Manolis. So this is very important that when we start using Mitraclip today, we essentially exclude these patients from future therapies. And I'm glad to hear that Francesco thought about it, and he believes that with La Punta technique or something similar, you can separate the clips from the anterior leaflet. So this is a question about whether it can be done or not, but it's good to know. But on the other hand, you know, the opposite side of what you asked is that if you start putting valves, replace valves in young DMR patients in the mitral position, transcatheter valves, and these patients will live for long. So we know that in the mitral position, transcatheter valves don't last very long, and you'll start having the Russian doll thing effect. You'll need to put a valve-in-valve and again and again and again. So the other option is not as attractive as well, to start putting transcatheter valves at young DMR patients.
Yeah. Can you put a Mitraclip in a degenerative bioprosthesis? Have you done it in cases? No.
I have a question about the long-term durability of the results after Mitraclip. The COAP study showed great results at 2 years, whereas I'm not sure if that actually reflects the experience of real-world practice. In your experience, what do you think?
So the durability is answered in 2 papers, the 5-year Everest 2 trial and the 5-year high-risk trial. And in both of these, what we found out that the requirement of surgery beyond 6 months is only 5%. So all the requirement of surgery took place in the first 5-6 months. But up till 5 years, after 6 months, the requirement of surgery was very thorough. So we think that at least it was durable up till 5 years. I have patients up till, my first patient was 2005, and she's now in 2019, and then she has mild to moderate MR with no symptoms. So,
Small number of patients at 5 years.
yes, of course.
More talking about the patient selection, after we have real-world practice, the clinical benefit of the trial showing.
No, but the 2 parts. One is that, of course, that's case selection. But you could have got a good result at 1 or 2 years and then seen some big surprises. Oh my God, at 3 years it's stenotic, 4 years. That we don't get, the scar. In fact, I had a patient who was operated in 2005 and had surgical repair in 6 years later. And Alfredo repaired it robotically. So he could repair the valve because he said the scar, once the scar develops around the clip, like any scar, it's a mature scar. So it doesn't matter whether it's 3 years or 6 years, it's almost the same scar. So yeah, you can, he excised the scar and he removed it. So it's not that the scar keeps on progressively going worse over time. The other thing is that the only patients who have progressive stenosis are patients with renal failure and dialysis. Those patients with renal failure and dialysis who develop MAICC, those are the ones which have progressive stenosis, but otherwise.
Calcification on the scar as well?
No, they don't. It's very interesting. No, not if they have renal failure or dialysis.
That's what I'm saying, the dialysis still.
Yes.
I think the question was correct. I mean, he make an important question because what we have seen in co-op trial is not the reality in everyday practice in Europe, where we treat end-stage heart failure patients. And probably in these patients, we don't reach the same outcomes that we have seen in earlier stage heart failure patients of the co-op trial. There are two reasons here. I think one is patient selection, for sure. The other one is optimal medical therapy and constant follow-up of these patients. I have to say, and I have to admit my mistakes. For many years, I have been reacting badly to Mitraclip. I thought, I've done Mitraclip, the patient is good, take off medications, take off diuretics. They go home and they feel good, you keep them off medications, and they come back after 6 months.
In fact, in the co-op trial, if you see the data, there was a 7 to 8% increase in beta blockers in the Mitraclip arm because their blood pressures started to become better. They tolerated the medication. So they used to go to the heart failure specialist. And the heart failure patients were independent. They were not, the patients in the trial, by the way, were not followed by us. They were followed by the heart failure specialist. So they continued, thank God, which is true. It also in the yes, and also in the trial, they are the ones who presented the case in the executive committee. And so they continued the medications as they would treat any heart failure patient.
But there is another important message that it is somehow new and requires new studies. What is the optimal medical therapy after device therapy? I mean, this is a total new field of investigation. I think up titration should be one of the targets of device therapy. Up titration.
Yes.
Down titration.
Absolutely. The problem is that we are at the moment in many institutions, we don't do this in a real teamwork approach. We have to find out also what is the right timing, what is the right therapy, what is the right combination of therapy for up titration afterwards. So, good question. And I think instead of saying I don't believe in the data, I think what we learn from this data. Can we improve our outcomes rather than say, I don't see these outcomes, so it's not true. I think we make a mistake here. Too late.
Same for surgical repair too.
The same.
It's all the same.
Same.
Once you mechanically repair something, you should be up titrating the medications for remodeling and all this other.
The other thing that you mentioned about the MR reduction was so good in co-op. It's not as good as you think because remember, 30% of people died at 2 years. So there were a lot of patients who are lost and we don't know what the MR was in those patients who died. So these are only in the surviving patients. So therefore this value will be less.
May I make a quick point? So is it okay? Thank you.
Yeah,
so a quick point, and thank you for having this kind of roundtable discussion that it's now evolved or devolved into. But so one of the points I'd like to make is that we have different definitions. So if you look, I was involved with the Cleveland Clinic arm of the study that Mike showed, the ischemic MR randomized trials with the CTSN. And it came out and everybody said at 2 years, failure 60% at 2 years. That was defined as 2+ MR. 2+ MR is a great success when you do a Mitraclip. Yeah, we scored, 2+ MR. So let's all use the same definitions as everybody's saying. It's the same thing that somebody presented yesterday. Correct. And so it says, the same thing was said yesterday, that we have all this great surgical literature about our biological valves with 40 different definitions of what constitutes valve failure, most often being reoperation. And if you die, you don't get reoperation and your valve did great, right? Even if it killed you. So that's one of the things we need to think about. The other thing I was going to ask, and I'd like to hear from all of the experts we have in the room, is right now for me, if I have a patient with a functional MR, I'm not sure I have the data to decide between Mitraclip, transcatheter repair, and transcatheter replacement, and surgical replacement. So 3 options: Mitraclip, transcatheter replacement, and a mechanical valve. So I would like to hear whoever wants to answer this, because to me it seems like I have three options, and I'm not really convinced if I know which is the best one.
So let's say this patient is a surgical patient. Let's say it's a surgical patient, right? A 65-year-old guy with the EF of 35% with functional MR, right? Who can have all the three options. So these are the patients that Alfredo Trento used to send me. He says, Saibal, my surgical repair is not going to last. I'm going to do a replacement. Yeah, I'm going to replace the valve anyway, so try the clip. He said the clip works, great. If it doesn't work, I'll put an MVR.
Yeah, but the problem with this is that then they have a therapy, we put them in the corner, and they get lost.
Well, no, that's a problem. They shouldn't get lost. Yeah, but that's different. That's a different thing.
Yeah, I don't
right
think
thing.
they should get lost.
They shouldn't get
You're
lost.
asking two questions in one. You know, the
And then
underlying problem is.
this is the only randomized set data which actually clearly proved that there was a benefit of a medical therapy. So how can you not?
Yeah, no. Yeah, go ahead, James.
Okay, and then we'll hear.
I mean, the great things about co-opt is the robustness of this. And you can look at relative risk reduction after so many medications that have evidence being put in place. But look at the numbers to treat. That's a absolute. And it's still incredible after all those therapies. So I think it's a no-brainer that those types of patients, Mitraclip is the way to go, and then go from there, because the other options are still there in the future if you cannot do a mitral clip and if there's failure. So I think this is the way to go.
Yeah, I just want to make a final, another comment that actually the Mitraclip trial being so positive, unexpectedly by many people, created a tremendous kind of worms now. Because, and the ultimate question is going to be both in the replacement as well as in the surgical mitral repair population that is being expanded on retrospective data and on, make sense type of data, and under also I would say the cloud of, is it feasible? Can we ever do a study of repair? And, that study is not feasible. It's never going to be done and things like that. Right now, or since 2018, that's now possible, doable. And many people, including many surgeons in the US, openly ask, well, what is a mortality trial of mitral valve repair that we've been doing forever and ever and this and that? And now that's very much on the table of why isn't there one, why hasn't been one for so many years, and why don't we do it? And from lay or simple-minded referring cardiologist point of view, the word of mouth in New York is always, hey, George, is it clippable? Exactly what Saibal says. I say, if it's not clippable, we'll try to figure out something else. Well, it's clippable, hey, maybe in a slightly different population, but, hey, there's a mortality benefit. Who has a randomized trial mortality benefit? So I'm saying the mindset is changing, and we're going to move towards a mitral valve repair trial, I'm sure.
Just one comment, and then Dr. Pitsis will comment. The other thing is we have noticed is that you actually might change the options of the patient by treating, at least temporarily, by Mitraclip. Patient who is basically ineligible for surgery, and we see that they improve quite a lot after a while under optimal medical therapy, and maybe an ischemic mitral later might be able to go for operation. So I would say it's a step forward. It doesn't mean, and we should always keep in mind that it's not a definitely therapy. If the patient improves and requires further procedures, it can be done. So that's another good, I think, tool for the future selection of the patient. Yes, Dr. Pitsis.
And also, just to carry on from Greg's point before, that if we have a patient with functional MR, surgical repair is still an option. And we have today various ways of repairing these valves. And we know that we haven't really explored all these new different ways, like the papillary muscle relocation. And I think that we need certainly data, we need trials. And I think surgery hasn't said the last word as far as repairing functional MR is concerned. I think we have new tools. Endoscopic mitral valve repair with papillary muscle relocation has excellent results. And I think future treatments like the clip should be compared and randomized against this type of surgery.
I couldn't agree more with that. Let me just say, what I concerned about, is this feeling, and Maisano is here, so Francesco, please comment, is that once the COAP trial became positive, we're all now looking at everything in a different light. As if, obviously, it's very important, mortality benefit, all the amazing things that everyone crying and getting up and clapping and all of this, it's because it was for these heart failure, no option patients previously treated with the maximal medical management, the very best, very, very small population, it's a sliver of what is mitral regurgitation. So let us not just be so crazy right now to say that a functional MR patient in whom is a great replacement or repair candidate, perhaps, could be given a clip in terms of, and pushing them into this trajectory, into this journey of, yes, you're going to get your valve replaced, not repaired, so let me clip it, and then I'll replace it a couple of years later. I don't know that that is the way we should be divesting patients. I think what we need to do is exactly what was just said by our surgeon, our capable surgeons who are able to, and believe me, I'm an interventionalist, I'd love to just do these things. I think we have to have, for functional MR, start to think about a prospective study. If you want to do this, go ahead, go in that, put that strategy as one of the arms, but let the surgeons, the creative surgeons who know how to repair, the ones who know, like Maisano, to go in that way, to go after a repair as well. And then let's talk about, is this clippable, and let's replace down the line. Is that the right thing we're thinking about for our patients? I don't know. And so that's me as a trialist thinking about this for the future, that you all should be thinking about.
I have a proposition.
The only question is not what we do, why don't we do it now? The question is, why haven't we done surgical repair for 20 years without anybody introducing the concept of a trial seriously? And it was a practical clout, and now that changes. Now that changes. Against medical therapy.
Can I put a little bit of quietness in the room, because now the trialists start to design trials. So first of all, you make already some confusion between what are we talking about, FMR or DMR? FMR. Very good. So FMR, there are trials actually which has been run. I would say the trial has been run. The conclusion of the trial, I don't agree, because this trial was a negative trial. Well, nothing happened in that trial. They saw nothing basically. Anyhow, but let's forget about this. Let's talk about the practicality of that. Surgery for functional MR. I have done this for many years. The problem of surgery for functional MR is the following, that it is high risk. Whatever you do is not comparable to the risk of a Mitraclip. And there is a trial, Matterhorn, in Europe, which is not enrolling patients, because these patients, we still are, we are not at the stage where we are convinced that treating MR works. So the heart failure community still say mitral FR shows negative outcome. So the problem is not this one. There is no interest at the moment yet in Europe in treating functional MR. In Europe, after COAP trial, I have seen 30% decrease of referrals. 30% decrease. For mitral. No, functional MR, sorry guys. Functional MR, surgery for functional MR is dead. Is dead. Is dead. I am a surgeon. I developed the geoform ring. I developed the IMR ring. I've been working on this field for ages. Is dead. Why is dead? Because remains replacement, which I can do percutaneously. I don't see why I should do it surgically, and annuloplasty, which I can do percutaneously. I don't see there any reason today. So if a patient comes with 2+ MR, let's say whatever it is, and cabbage, he gets only cabbage with me. And I see what happens. It comes back in 6 months, and I see what happens, and then I can do annuloplasty, Mitraclip replacement, whatever. And I reduce the risk of the procedure, because off-pump surgery has a risk of 1%. if I do on-pump surgery, bypass plus MVR or repair, is not less than 5%. So as a patient, I'm sorry, I don't want to try it in this field. I don't want to try it. I don't want to risk my 5% versus 1%.
Sorry, but what about a surgeon who cannot do all that you are doing? Because this is the field. I mean, not a lot of surgeons can go after 6 months to do a Mitraclip.
There will be Spargius who comes. It's not a problem. You know, we should not be limited by what we can do or what we cannot do. We need to build around these opportunities and break these walls that we have between this operating room and the cath lab. Sorry, guys, this is bullshit. It's finished. Well, not yet, but we need to finish that. Because the patient needs this portfolio, and the portfolio should be offered without the bias, which is a bias here in the pocket, or is a bias of career, is a bias of power. The patient have now new opportunities. And so as a surgeon, I am a director of a surgical clinic, and I believe that we need good surgeons who can do sternotomy, who can do thoracotomy, who can do whatever is needed for these patients, as well as I think we need physicians who are able to do this percutaneously. Don't look at me, I can do both. I don't care, I mean, it's unique. We don't need that. But we need a team which is offering the platform. And in this platform, you need to not to forget what the surgeons bring. I mean, I come to you and say, listen, yeah, you want to do surgery, but I'm scared. I'm scared. 5% mortality is 5% mortality. You can't go lower than that. And actually, in Milano, high volume center, one of the highest in the world, it was 7% the mortality for functional.
Let's hear, let's hear Dr. Pitsis, an expert, pioneer, surgeon in Greece. What you would say?
I would agree with Francesco to most of it, but I would say that in the last 10 years, there are plenty of centers around the world that they have started developing robotic and endoscopic programs. So surgery has changed. Surgery is not median sternotomy. Surgery has become less invasive than it used to be. The results have started to become better and better, because of the less surgical trauma. And I think that we know today, we have learned a lot from our mistakes in the past. We have stopped using undersized endobronoplastia as the only way of treating functional MR. There are many, many other ways of treating functional MR. So I think we have to see what state-of-the-art surgery has to offer as well. We shouldn't say we can clip it, we'll clip it. I mean, today in my center, which is also a high-volume center in mitral and tricuspid repair for functional MR and degenerative MR, we treat all these patients endoscopically, and we have excellent results. And 5% mortality is something that clearly we don't see anymore. We see a lot less than that for mitrals. For tricuspid, you are right, it is 5%, but for mitrals, it's a lot less than 5% the mortality. So I think we have to
special selection. I mean, not that I cannot treat my mitral compression surgery, so they will die in induction anesthesia. So, sorry.
Yes, we are talking about surgical candidates.
We're making again a mix. I'm not discussing surgery. Surgery remains, and guys, we need to educate the interventional community that without cardiac surgery there would not be any modern cardiology. Cardiac surgery established modern cardiology, because before cardiac surgery there was no treatment for heart disease, and cardiology was a small area within internal medicine. Thanks to heart surgery, cardiology was born, and afterwards interventional cardiology, which is at the end surgery. At the end is modern surgery. Thanks. Thank you. But
sorry,
we're talking about
we don't have plenty of time to go on.
Yeah, but that's good. We're talking about technologies, not talking about patients now. Yes, for sure, robotics, minimal invasive, all good. But it's about the patient selection and the proper mix of opportunities without boundaries. And obviously we need experts like you doing this minimal invasive with a robot and so on.
Just a last comment, trying to reconcile all these different approaches. Roxana, do you think we can use the surgical arms of the Apollo trial? Probably it will be redesigned, and the surgical arm. Okay, then the tendine surgical arm to solve these issues, because there will be surgery for these patients. Can we have a stratification there between Mitraclip, robotic?
You wish you could do that, but these things, it's just, first of all, you can't take the surgical arms from one trial and compare it to another. It just becomes very, very difficult. But within the same trial, it's really, really hard. If you put multi-level stratifications as it is, the trials are difficult to interpret. The reason why COAPT was so easy to interpret was because of the fact that they just really worked so hard. It took 7 years to finish that trial. And they worked so hard to get the exact right population that they were really intending to use the device for. The heart failure patient who fails everything and still has a big orifice, effective orifice area, and has mitral regurgitation, and is on maximal medical management. That's when they randomized these patients. And then they gave the medication. They worked hard on both of the arms and were able to achieve this kind of a success. This is how we should be thinking. If there is a population that you believe you have a question on, an unmet need, which was this right here, then you can design a study and be patient. And the saddest part is to watch patients die in the control arm. Watch them die, and don't change your direction to start crossing people over to and then you lose that effectiveness. You never reach your answer. And what was great about that clinical trial is the fact that everybody stuck to their guns. They watched, patients were dying. I can tell you, the reason why everybody cried is because this guy put the Hollywood right up there. We were all still thinking about his patient who died, and then comes a trial that shows positivity because there was no crossover. These are the way, if you design a really eloquent study, you can get your answer when you have a major question, but you have to stick to your guns. Stratification, this, that, use this arm compared to the other, this is when you fail.
Okay.
Thank you for the interesting discussion. We have to move for the next presentation. Just